Breast reconstruction with implants or expand. I watched earlier. Interesting to see your thoughts. After having my implant taken out on July the 17th, due to pain caused by the radio and now pain-free down to steroid injections and acupuncture. Fantastic. Thought I was going to have it put back in, but got told on Tuesday I have to go have an expander put in first. Then hopefully be lights end of January. Didn't know if that was your thing to talk about. Yeah, it is my thing to talk about. This is a breast reconstruction question, and this is a problem. And what I would say is breast reconstruction is different to breast augmentation. Often implants are used, and you might think that it's a sort of similar thing, but it's not. It's a different entity altogether. It's got much higher risks, complications, and it's, broadly speaking, much more difficult. And my thoughts about this are that at the end of the day, with breast reconstruction, you've got to work with your surgeon, work closely with your surgeon, and get a plan, because there's pros and cons with anything, and sometimes it's difficult getting other people's opinions because they might conflict with the opinions of your surgeon or someone that you trust, and then you might think, what's right? There's no right or wrong. But I would say that my thought about this is you've had obviously had a mastectomy, and you've had radiotherapy, which has been extensive because it's caused you a lot of pain. You've had to have the implant removed due to the pain, and you've had steroid injections, acupuncture, and this is the problem with implant-only reconstruction. When you do an implant-only reconstruction for breast reconstruction, it's a totally different thing to a cosmetic augmentation. Sometimes people think, oh, great, I'm going to get breast implants. It's totally different to cosmetic augmentation. A cosmetic augmentation is a situation where you have a breast and you're enhancing that breast with an implant. You put the implant behind the breast, whether it's in front or behind the muscle, it's always behind the breast, and it's enhancing that breast. So everything that you feel is breast tissue, and the implant is just enhancing the natural breast. When you do a breast implant for reconstruction, it's totally different. There's no breast. So all there is skin. You always put it behind the muscle. So you try and cover the implant with muscle. But there's just skin there, and it is what it is. It's an implant and skin, so it looks completely different. There's no natural movement, there's no natural droop to the breast. It's really, and this is my experience and my view, it's really good for smaller breasts. I would say something around a B cup. It depends on the width of your frame as to how big an implant you can use, but you can't reconstruct a very big breast with just an implant. And it does have limitations, particularly in terms of the other side, because the other side, your natural breast, will move, and when you take your bra off, it will sit lower and it'll have a natural move and a natural flow to it, whereas the reconstructed breast will not move. It might fill the bra in terms of in clothes, it might be a good thing, but out of clothes, it will never have great symmetry with a natural breast. And I'd be concerned that you've had radiotherapy. Now, radiotherapy is a relative contraindication to having an implant-only reconstruction, because radiotherapy damages your skin. It zaps the area and it kills all the cancer cells, and it's fantastic at killing any residual cancer cells that's going to be there, but it will also damage your skin, and it will scar your skin, not only scarring in terms of what you can see, but deep scarring, and it makes the tissues very woody, very firm, and it makes it move even less. Because it scars everything, there's a very high rate of capsular contracture hardening around the implant. That can happen with anyone. It happens in people with cosmetic implants, cosmetic augmentation, but it's an even higher risk in someone who's having a breast reconstruction who's had radiotherapy. There's an extremely high risk of getting a capsular contracture, scar tissue forming around that implant. And so it's a relative contraindication. It's not a great way to reconstruct the breast that has had radiotherapy. And so I would be concerned about the fact that you've got pain, you've had to have your implant removed, and now you're going down the road of having another implant. Because I would say, look, that's going to get pain again, isn't it? And that's going to potentially go hard, and it's not a fantastic option for reconstruction in someone. Oh man, I get this every time. A battery. for someone who is having a breast reconstruction. Also, the question is about having an expander put in first. Yeah, that's standard, because what happens when you have the implant removed, all the skin recoils. Not only the fact that radiotherapy there, but in a normal patient, the skin recoils. And because there's no give in the skin, it's very hard to get a fixed volume implant back in. And so it's very common to have to put an expander back in. As I say, you often need to get total muscle coverage when you use an implant for reconstruction. Completely different to a breast cosmetic augmentation. When you're putting cosmetic implants in, you only put the implant under the pec major. A lot of people say, oh, I fancy a dual plane. Dual plane means half of it's pec major, half of it's on under the skin. They're all dual plane. There's different levels of the dual plane, which is something you can talk about, but all implants in a cosmetic patient are just under the pec major. The pec major is a muscle that goes across here. This part of the implant is always is not covered by muscle. When you're doing a reconstruction, you want to get all of the implant covered by muscle, so you often raise up the serratus anterior, other muscles in the area, basically the rectus, to get complete muscle coverage over the implant. And because you're trying to get complete muscle coverage over the implant, the muscle doesn't give as much as the skin, and so you often have to put an expander in a flat implant and then blow it up gradually in order to get a good volume of implant in. So it's completely normal to go expander first, but I've got to say and then B-lights, yeah, fine. B-lights are silicone implants, very high risk of capsular contracture with silicone implants in patients who've had a breast reconstruction, for a breast mastectomy followed by radiotherapy. So that would be my concern, but obviously you're working with a surgeon, whether you're a plastic surgeon or a general surgeon trained in plastic techniques, so breast reconstructive surgeon. But yeah, that would be my concern. But anyway, all the best with it, and as long as you've talked about all this stuff, then good luck with everything. But it's a normal thing to go be expander first, then implants. So I hope that's answered that question.